The NICE guideline on shared decision making gives some examples of using numerical information to help patients decide on medicines and treatments. A key component of this is the use of figures to quantify risk, as the same information can be presented in ways that look very different. This is important for us clinicians and for patients, as the pharmaceutical industry tend to use relative figures rather than absolute figures, because these figures can present a more optimistic picture. The information in this short vlog and more is contained in this video by James McCormack. If you like learning through the medium of song, I recommend it. I used to use this video to prepare me for the calculation exams we had to undertake when I was a NICE Medicines and Prescribing Associate. It contains all the key points. There's a short one-page paper in the references section from the University of Western Australia which sets out a concise description of how to understand absolute and relative risk reduction. Basically, the relative risk reduction is simply the difference between the event rates, that is the number of times something happens, expressed as a proportion between the treated and untreated group. In other words, a straightforward comparison between two things. The absolute risk reduction gives you a much more realistic picture. To calculate the absolute risk reduction, you also need the number needed to treat, usually referred to as NNT. The relative risk reduction stays constant with different populations, whereas the absolute risk reduction alters with different populations and would be much greater if the population has a higher baseline risk. The number needed to treat, NNT, is also important because you can use this to consider the benefits of a treatment for different population groups. If the baseline risk is high to the patient, then the treatment is likely to be worth giving. If the baseline risk is low, then the risk of side effects, interactions and adverse reactions and the cost of the treatment, including any cost to the patients, such as having to attend clinics, monitoring, etc., may outweigh the benefits. Our evaluation of research depends on what the study is looking at, that is the event rate. For example, death or serious illness. Here's a pause for reflection. Have a look at studies promoted by the pharmaceutical reps. Do they use relative or absolute figures? What extra information would you ask for? Other ways to look at the evidence and numbers include, firstly, who's and do's. That's patient-orientated outcomes and disease-oriented outcomes. When you review a clinical study, what was being examined? Was it something meaningful to patients, for example, allowing them to lead a longer life, prevention of strokes, improved quality of life, reduction in the number of episodes of illness? Or was it surrogate results? For example, the study showed reduced blood sugar levels, reduced lipid levels, or led to something that showed up on an X-ray or scan. Is this meaningful for patients? Is the benefit to the patient from taking the new drug clear? Studies that look solely at surrogate markers may not be very useful in the decision-making process. A surrogate marker is defined as a laboratory measurement or physical sign that is used in therapeutic trials as a substitute for a clinically meaningful endpoint. That's a direct measure of how the patient feels. So on their own, they're not very helpful. Secondly, on a personal reflective note, based on my area of practice, which is mental health, and related research, it's worth asking ourselves which came first, the drug or the disease. Some commentators argue that along the lines that certain disease categories, such as for example generalized anxiety disorder, came into being because they fitted the drug, rather than the other way around. If this is an area of interest for you, have a look at the work of Dr. David Healy. I've touched on some big subjects here. There's much more information we need to help us evaluate clinical studies, particularly in looking at how they were conducted, which will help us and our patients make informed decisions. I hope this short vlog will remind and encourage everyone not to take presentations of research papers at face value. Question everything. And don't forget that regardless of the evidence, decisions are made by patients based on many factors, including their circumstances, past experiences, their family and friends, their ethnicity and culture, financial situation, health beliefs and values. I hope you found this useful and it provides materials for reflection and discussion. These, of course, can be used in your appraisals, in peer reviews and for revalidation. You can find a template for reflection here.